Before we get started, just a quick word from World Extreme Medicine. If you work in pre-hospital, remote, expedition, humanitarian or high-risk environments, World Extreme Medicine exists for one reason: to help you deliver safe, effective care where resources are limited, decisions matter and help is a long way off. From expedition and wilderness medicine to hostile environments, dive medicine, leadership and human performance under pressure, World Extreme Medicine bring together clinicians and operators with real-world experience in some of the most challenging settings on the planet. Their courses, webinars and global faculty are built around practical decision making, not just theory, to focus really on what actually works when things go wrong, far from definitive care. To find out more and explore upcoming courses and indeed educational content, visit worldextrememedicine.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Hello and welcome to the Pre-Hospital Care podcast. Today I'm joined by Nikki Hewitt and we're going to talk about ECPR, ECMO pre-hospitally. Nikki's been one of the first paramedics in the UK to deliver pre-hospital ECMO as part of London's Air Ambulance Enhanced Cardiac Arrest Team, ECAT. She's going to talk us through the evidence behind ECPR, the ECAT setup and the paramedic role within the team, as well as where the future lies for this intervention. Nikki, welcome to the podcast.
Thank you for having me.
Nikki, do you want to just talk us through a little bit? What's your background? Where did you start off as a paramedic? What does your journey in the profession look like?
So I started my paramedic journey in 2009. I did a 2-year diploma at Liverpool, John Moores University, qualified as a paramedic in 2011. And then I worked in the Northwest with NWAS for, I think, best part of 10 years as a paramedic within their ambulance service. And as part of that, I did a few years on the Northwest Air Ambulance as a HEMS paramedic. I did a few bits and bobs of overseas work and just to add a bit of variety to my sort of paramedic skills and training. And in 2020, I moved to London and started a role as an advanced paramedic practitioner in critical care. And as part of that, in the last couple of years, have become involved in ECMO in London. Although I did actually start my sort of interest in ECMO when I worked with the Northwest Air Ambulance back in about 2016 to 2019 there, as part of our services there. At one point, this is all pre-COVID, obviously, we did have a pathway with one of the hospitals up there for ECPR. And then since moving to London in the last 5 years and realising how privileged the population there is to have access to multiple ECPR centres, but without any formalised pathway to access the services, I undertook a project to implement one. So that went live in 2024. And then when there was talk of a pre-hospital ECPR team, I was, of course, interested. So yeah, that's how this whole thing started, really.
Yeah, it's really cool. I think it's such an interesting topic that obviously a lot more people are aware of and are familiar now, because the ECAT team's been live. There's a lot of teams that are looking to implement this, but there's still quite a lot of I guess confusion and not a lot of people out there that aren't completely sure exactly what the intervention is, what kind of what the benefit is, all the bits to it. So yeah, it's great to have you on and have a chance to have a talk about it. I remember when I started doing APP stuff, it was pre-COVID as well, and we, again, talking about being lucky in London, Paul Rees invited us to Barts when we did some other cardiology stuff as part of our training, and we got invited onto one of the wards to see some actual patients that were having ECMO. And at the time, I remember my mind's being completely blown by the whole concept. It's fascinating, and I think the fact that we are able to deliver it pre-hospitally now in itself is incredible. But let's get into it and talk about it. So I guess first off, I hear a lot of these terms getting thrown around and used interchangeably, ECPR, ECMO. Could you talk me through exactly what is it you're doing? What are you doing? What it is that you're doing? Why is it so pioneering? And perhaps just, correct me on some of the terms that I've been using. It's not a little E before the CPR I've learned already today. So yeah, even in my preparation for this, I'm still getting stuff wrong. Can you set the record straight, mate? Tell us exactly what it is.
Yeah, of course. So, I think if we think of ECMO as like an umbrella term, which incorporates a few different modalities of care, so included under the ECMO umbrella is VV ECMO. So that's a respiratory support only. So, that would be used for patients who are in respiratory failure, whose lungs aren't working, basically. And then you've got VA ECMO, which is both cardiac and respiratory support. So VA ECMO is typically used for patients in cardiogenic shock, but it can also be used for patients in both cardiac and respiratory failure. But VA ECMO can also be used for ECPR. So that's extracorporeal CPR. So undertaking ECMO for patients in refractory cardiac arrest. That obviously needs to be VA ECMO because they require cardiac support, not just respiratory support. So yeah, the evidence on ECPR has shown a strong correlation between time to ECPR and neurologically intact survival. So that's not something which is surprising, really, as we know with all cardiac arrest patients, the longer they're in cardiac arrest, the less likely their brain is to work afterwards. But with centres located sparsely, even in London, but mainly outside of London, the way to improve equity of access for ECPR to patients is to take a ECPR to them, which is the sort of whole concept of pre-hospital ECPR happening in the first place.
And kind of like one of the fundamental tenets of all pre-hospital care, right, is, you know, bringing certain select interventions to the patient because we know that time is everything, right? With regards to ECPR, you talked about VA and VV ECMO and the differences. Can you talk us through like exactly, you know, for those perhaps who haven't seen it, haven't seen the setup, the equipment that's involved, how are you, very, very fundamental basics, how are you achieving that, effectively getting these people on this sort of external life support, big lines in big vessels, right? And then a pump. Do you want to talk us through that a little bit and just so everyone's clear?
Yeah, so like the basics of what ECPR does for the patient. Yeah, sure. So effectively, you have got a machine that is an external heart and lungs for the patient. So you'll put a big pipe, like you say, in the patient's femoral vein that then, under negative pressure, pulls blood out of the patient from their inferior vena cava and pushes it through a membrane. Now, that membrane has oxygen moving across it. So as the blood goes through the membrane, oxygen diffuses and attaches to the hemoglobin, CO2 diffuses out, just like what happens in a patient's real lungs. Then the blood passes through a pump, which then drives the blood back. So like the heart, the pump is the heart, passes blood back into another big pipe, which then sits in the patient's femoral artery and up into the aorta and pushes blood back in with approximately the same flow as what a working heart provides. So in that external box, you've got heart and lungs for the patient, and it is doing the job of the heart and lungs whilst that patient's in cardiac arrest and obviously can't provide that support. And because obviously the benefits of that being like a physiological flow means that the patient gets the same oxygenated blood to their vital organs than what they normally get, not what they get during CPR, which is approximately a third of physiological blood flow.
Awesome. So it is effectively, for my very, very simple brain, it is like having a machine that is your heart and lungs outside of the person's body with some big plastic tubing that goes into some big vessels in someone's groin and yeah, is effectively taking over the job of the heart and the lungs whilst they have a nice little rest. So someone's got to obviously run the pump, someone's got to put in these big lines into big vessels, which is no easy feat by itself. And then on top of all of that, someone's got to do all of the traditional cardiac arrest management stuff, including managing the airway and thinking about 360 access and extrication and all of that stuff. Is that pretty much the crux of it? Am I missing anything?
Yeah, so I mean, you make it sound very simple.
Yeah, if only. But yeah, is that am I missing anything? Like sort of as like a fundamental, is that pretty much like what we're talking about?
Yeah, basically. So we're trying to do ECPR, as you've said, via the process that I've described, alongside like ensuring good quality ALS is going on. So we don't want to detract from still trying to get a ROS, still trying to provide good quality resuscitation to a patient. So those things have got to be done simultaneously.
Can you talk us through some numbers? So I guess like, how what's the availability of the team at the moment in London? Like how often are they working? Just a little bit through how you're getting dispatched maybe. And how many patients you're seeing.
Yeah, sure. So ECAT went live in February 2025, so 11 months ago, just under a year. And in that time, we have staffed 44 shifts. So that's approximately one a week. We have attended 25 patients in cardiac arrest in that time, and five of them have progressed onto ECPR. I think it's worth noting that currently in its initial stages, we've only been able to provide a team one day a week on average. But that is because, it's a small team. All of those involved in the team have other jobs. And then we've had to consider as part of the initial stages, the training requirements for those team members to make sure they have regular exposure to the intervention, the cost involved, how to maintain currency, and how to get them to the standard in the first place to be able to undertake that. So yeah, that's sort of how it's worked over the last 11 months.
And alongside that, obviously, the APPs in London have had a pathway to get select patients directly onto ECMO with a phone call, and that was agreed by all of the ECMO centres. That's been running for a little while. I know you were like integral to setting that up as well. That must have been a challenge in itself. Like, how many sort of patients do you know how many patients we've been able to get on the pathway? I know certainly when it was first set up, we kind of thought, well, we get quite a high volume of medical cardiac arrests in London. We're normally pretty close to the four centres: Harefield, Barts, King's, George's. Is that the four?
Promises.
Oh, St Thomas's. Sorry,
Yeah.
yeah, not George's, St Thomas's. Pretty high footfall in that area. We see a lot of medical cardiac arrest. APPs always floating around there. Certainly felt like we'd be able to get a lot of patients in, and it's 45 minutes. Is that right?
Yeah, that's right. So we want ideally the patient needs to be from the time of their cardiac arrest to arrival at an ECPR centre within 45 minutes. That's just based on the evidence of they need to have any chance of a neurologically intact survival, they need to be on ECPR within 60 minutes. So that gives us 50 minutes to get in there, handover, and for the team to successfully put them on, which, is the whole thing's a challenge. I mean, you could think an hour sounds like quite a long time, but these timeframes can really, really quickly go by the time you've, driven to scene, got there, got a history, established ALS, try to extricate, transport, get them in the hospital, handover. That 45 minutes can really, really buzz by, especially if you've got a distance to travel to the ECPR centre. And then in terms of numbers, so for our APP pathway, we have had this year we've had 8 activations and 5 of them have had ECPR performed. So we know that we are selecting the right patients. That's a very high number. And of the 3 this year that didn't go on, they were all in a sustained ROSC, and that was why they weren't eligible for ECPR. So that's, positive outcomes there in terms of like our patient selection criteria. And that pathway went live in 2024. So in total, we've had 13 activations, but it went live partway through 2024, and then there was a cyber attack which took the pathway offline due to issues at some of the hospitals for a number of months. So I mean, this year has been the first full year where we've had an active pathway. So in total for both pathways, we've this year delivered ECPR to 9 patients, which is pretty high numbers really. I think it sound low in its nine patients in a year when you look at how many patients have cardiac arrests in London. But then if you look at how many of those were shockable and how many of those were witnessed, actually, the numbers do creep down. I think the numbers were a lot lower than everyone's expected, prior to these pathways going live. But I think it is all about patient selection and managing those vital resources appropriately.
I think actually, you were saying earlier, from the APP pathway, did you say you've had 8? And you've got 9 on as the ECAT team, and then there's been 5 that have gone on to ECPR from the APP pathway. That's 14. That's more than one a month from 2024 from last year, with both services combined. Is that right?
So 5 have gone on for ECAT.
Yeah.
Yeah,
And you said that the APPs are
5 have gone on
28 and
for.
5, so nearly one a month. And I think, I often think about, there's that classic argument around, we're going to talk a bit about health economics and stuff in a bit, but I know people often say, oh, we should just put all of our money into public access defibrillation and teaching everyone how to do CPR. And I kind of, I've my opinion on this, after thinking about it a lot, is that, and hearing other people talk about it as well, is actually you've kind of got to invest in every bit of the journey. Like, yes, like the public access defibrillators, just recognizing CPR, that stuff's incredibly important. We know how important that stuff is, but also all of the stuff down the line needs investment as well. You can't just put all of your eggs in one basket when it comes to this stuff. So yeah, I think it's really interesting. It's great that obviously, you guys are trying to push the boundary and innovate and yeah, move things forward. I know you sort of talked a bit about the team and the pumps. What's your setup as a paramedic within the team? So, you guys, the klaxon goes, you get a job. Maybe talk us through from that. So the calls, obviously the APPs are in the control room there, finding the calls and dispatching the team. What are the patients that they're looking for to dispatch, and what does that sort of process look like, specifically from your role as a paramedic? So I guess maybe from the control room and then through to when a job comes down to delivering ECPR.
Yeah, sure. So, yeah, the dispatch is absolutely vital to this whole thing working. As we know, as APPs, our dispatch is integral to the system working properly. Finding the jobs is, if you can't find the jobs, then there's no point any of it existing, really. So, we rely on both the APP in the control room and the HEMS paramedic in the control room, and we are quite privileged that we work together quite closely. We sit next to each other. And so the decision to dispatch will be based on information that they both gather. As to the appropriateness, we're lucky enough to be able to listen into the 999 calls as they come in, so we can get that real-time information. And a lot of it is from what you hear. Do you think this was witnessed? Because some of these questions that we're trying to answer are not questions that the call taker asks. So we're trying to think, if it's in a public place, it's more likely to be witnessed. So that might influence our dispatch. If it's in a home address, do we hear the caller say that they came in or they came home and found the patient in collapse? So that might make a difference. But what we're looking for from a dispatch criteria, in its sort of basics, is this a person who has had a sudden cardiac arrest and is having bystander CPR? And are they relatively non-frail? And that will probably be enough to dispatch. Obviously, time is of the essence with these patients. And so if you wait for too much information, you may have lost the time benefit. And if you dispatch too early, then you may get your team just absolutely fatigued by constant dispatch. So it's finding the balance right. But basically, yeah, so it's up to the APP to find the job, the HEMS paramedic to dispatch the resource. And then the team will be notified about the call by radio. And then over the last year, how that's worked is then they'll also be notified of their mode of dispatch. So that will be decided by the HEMS paramedic in the control room, depending on where the job is and sort of any operational things going on that day. Is the aircraft available? Are they already busy on a trauma job, etc.? So it will be by air or by car. Then the team will mobilize, and when they arrive at scene, then they'll have standardized clear roles, which has been repeatedly drilled in training. Obviously, what we can't repeatedly drill is all of the external factors that might change how a job works and its dynamics, who's already there, what's already happened, where the patient is, etc. So, but we'll try and slot in to the current job as we arrive and stick to our assigned roles. So generally that involves the HEMS consultant will begin to get gowned up, as this is a sterile procedure. They'll place a drape over the patient, start to chloroprep the groins, and under ultrasound guidance, they'll then be focused on placing vascular access cannula in the femoral artery and the femoral vein. And then we'll have an ECMO proctor as well in the team, and they'll be working alongside that HEMS consultant. They'll be ensuring they've got the equipment that they require to undertake those things very quickly. So they'll be opening and prepping the equipment. They'll be assisting them to place the wires. They'll be preparing any ongoing equipment related to exchanging then the catheters that they've put in for ECMO cannula when that time comes. And then the ECMO proctor, once the initial equipment's open, then they'll become sterile to be able to assist with that HEMS consultant roles. And then whilst that's ongoing, the paramedic is responsible for preparing the ultrasound, obtaining a history, so ensuring that this patient meets suitability for ECPR, but also alongside that, making sure that high quality resuscitation is ongoing, ALS is established. Have we done everything we can to try and get a ROSC in this patient? And yeah, ensuring that the suitability for ECPR is met so that the HEMS consultant and proctor continue with their roles. If there's any intervention that needs undertaken at that point that the ambulance crew have been unable to do, then the paramedic will be responsible for that as well. And coordination with the team on scene is also really important part of the paramedic's role, because this might be something that they've not seen before, and it can seem a bit crazy really, because you've got a team that turn up that literally just start doing stuff as soon as they've turned up. So the introduction of who we are and what we're trying to do will also be the paramedic's role. So once those things have sort of been sorted, they'll move on to prepping the cardio help. So all of the paramedics have been trained by perfusionists. So they're the ones who manage the ECMO machines in the hospitals, but they obviously don't work pre-hospital in the UK at all. So they've sort of trained all the paramedics in how to manage the cardio help pump, from priming it to doing the daily checks on it, to setting it up at scene, for managing it when there's a patient on it, and for management of any pump emergencies. The paramedic also confirms wire placement with ultrasound, and then they'll be responsible for running a stop check. So that's where the whole team will just pause, except for the ALS will obviously continue. But the ECAT team will do a stop check. We run through a checklist of eligibility, make sure the patient still meets criteria. And if they are a goer, then paramedic will heparinize the patient, pass the ECMO cannulate over, and continue with preparing the cardio help. There can be a lot to do, because that is a lot of roles if everything is going to plan. So when things aren't going to plan, then it can be even harder. So, if the patient's only access is in their tibia, that will now form part of the sterile area. So we won't be able to give our ALS drugs through that. So the patient will have to have new access placed sort of above where a mechanical CPR device would go, so that we can continue to provide the drugs. So yeah, there can be a lot to do. It is really important these things are undertaken quickly and efficiently as well. So it can be a challenge. And then once on ECMO, there's still more roles to be undertaken. So the HEMS consultant is responsible for securing the cannula, placing an arterial line for monitoring, and the proctor will oversee those things. They'll start trying to get rid of a lot of the equipment to make it easier for us to move. And they'll also keep an eye on the cardio help while the paramedic manages extrication of the patient, because now they'll be on a monitor on a cardio help machine. They'll have long, big, massive pipes, which if get pulled out can be absolutely disastrous. They'll need to go onto a ventilator. I mean, if intubation didn't already happen, then that needs to be done at that point. We'll also look at what rhythm the patient's in now, whether we need to deliver a shock if appropriate, whether there's any need for inotropic support, whether there's any sedation or paralysis needs. So yeah, there's a lot to go on, but I think due to we did a year of training and drilling and trying to work out how would this work best, defining these three separate roles. So I think everyone's pretty comfortable with what they need to do and how they can support the others to do their roles efficiently as well.
Not quite just putting in two big tubes and a little on-off switch on a pump then, as I sort of had it in my head. I think before coming up to the London and seeing the whole setup on the pad. And yeah, and I think to your point as well, like, like CRM and stuff like that with ambulance crews, because I imagine when you guys turn up and do this, a lot of them, like their heads will fall off in the sense that, it's probably not like anything they've seen before, and certainly not what they're expecting, especially in London. You know, they're used to seeing London Hems, people turn up wearing orange flight suits, and it's very much like it's trauma, and you know, it's a bit more sort of grubby and dirty. You guys turn up and put big gowns on, and you know, make everything sterile, and it's very different, isn't it? So yeah, I guess so. The three roles, you got a proctor, who I'll be honest, I'd never heard of a proctor before you guys started doing this. Sounds like something out of I don't know, either Harry Potter or sort of Lord of the Rings or something, like the proctor of the Whitechapel. So correct me if I'm wrong. The proctor's kind of there as a bit of a safety net, kind of general overview person to make sure that everything is being done safely. Is that correct?
Yeah, exactly. And actually, in the initial like phases of us thinking about how this was going to work when we started doing our training in 2024, we started initially trying to plan for a two-person team, so a HEMS consultant and a paramedic. And obviously the ECMO doctors were involved in this because they're the ones that are having to teach the HEMS consultant and the paramedic how to put these cannulas in and how to then upgrade it to ECMO cannulae. And a lot of it was obviously very unfamiliar to the majority of the people in the team. And there was so many, you know, I've just obviously read out all of the things that we're doing for the three people, and we're very busy between us. I don't think at any point there's anyone standing around with it, you know, waiting for anything. So imagine then that was trying to divvy out all of those jobs with two people. So it was a lot to do. And then we had a visit from Natalie Cruitt, who is the ECMO consultant who's running the sort of their version of ECAT in Sydney. And they're sort of a year ahead of us. And so they gave us a presentation on what they'd been doing and how, you know, what they'd found, and what they found worked, what they found didn't work. And they had developed a three-person team, which included Natalie in a sort of proctor role herself. So we looked at that point, we were only a sort of couple of months into trying to work out how we were going to deliver this. So we changed then to this three-person team, which included an ECMO proctor. And yeah, you're totally right. They are like an overseer. So these are people that are experienced in putting patients on ECMO and putting these lines in, mostly in a hospital, but nonetheless, they're the people that know how to do this. So they are the ones who've taught the HEMS consultants how to do this. And then they're right next to them on their right-hand side, supporting them, providing the equipment to do it, overseeing everything. And they're obviously also familiar with the cardio help machine and are able to support the paramedics if they need any support with anything that crops up with that. So yeah, we moved to the three-person team, which I think from an individual role thing made a lot more sense, from a decision making, if there's any difficult decisions, or if you know there's any challenges with the care post ECMO, makes it a lot easier, a lot more like supported. And we also have a team of external experts that we can reach out to on a job to say, has anyone got any ideas? Can you provide some help with this, that work at the ECPR centres across London? So we're quite a privileged position to have that ECMO proctor to oversee. And you know, I think when we initially started bringing that role in, it was thought maybe in the future that person may not be required. So you know, that is an option to then potentially move to a two-person team. But once we've got it really set in as what those individual roles are, where everyone's comfortable, especially this whole thing is so new, and like you mentioned before, these ambulance crews won't have seen anything like this, and it's specific to London. HEMS are a trauma team, aren't they, in London, which isn't a thing in the majority of the other HEMS services. So yeah, it can be quite confusing for ambulance crews to see a HEMS team turn up to a medical job. And so yeah, I think having the three-person team just allows a little bit more flexibility and support to provide information to the crew. And you know, we can't do this without them. Absolutely, they're, you know, one of the most vital parts of this whole thing working effectively. So having them on board and allowing them to be part of it is really important.
So I guess as the paramedic, like, you know, the things that your strengths and that you're bringing to it are, you know, you've got a lot of experience with pre-hospital medical cardiac arrest. Obviously you've done some HEM stuff previously with Northwest. Great, I always get them confused. The one up north that you did.
Northwest, yeah.
Northwest, thank you. Apologies, Northwest, if anyone's listening. And yeah, so you've got to be familiar, comfortable with working on a helicopter. Like, it can be quite disorientating, can't it, when you first start, and you land to a job and everything's, you sort of like, you lose your senses for a little bit, don't you, in terms of your hearing and stuff. You got to quickly switch and adjust. CRM's obviously a really big thing. There's a lot. That's a lot of people on a job, which in itself can be quite challenging. You've got to, you guys have got to do your thing whilst also making sure that everything else that's going on is still being done well. Yeah, lots of pieces of the puzzle, as well as having all of the specialist practice, advanced practice knowledge around use of ultrasounds, using other drugs that perhaps other people won't be familiar with, like, heparin, sedation needs. Like, it does sound like there's a lot to it. And on top of that, you guys normally quite like an APP if there is one available to come and help out as well. Is that right?
Yeah, absolutely. Having an APP at scene is, I mean, we started off being like it's like a non-negotiable, really. We need the APP to be at scene when we were sort of doing our training. But then, ideally on any day there might be 4 or 5 APPs pan London, and assuming they are not on a job, then that's the highest cover that we'd have. So, if you take off a few cars on that day and then the other 2 are on jobs, then you won't get an APP. And what we didn't want is that to reduce our patient selection just on the basis of whether we can get an APP to scene or not. So yeah, it's not an absolute, but it makes our lives so much easier. Obviously, having a CCM there also is pretty important. I mean, ideally we need mechanical CPR device for these patients. So a CTM or an APP for their equipment, but also like having their skill sets, their leadership skills, and being able to have some confidence that actually what I can do is leave the APP or the CTM to manage ALS, and for me to not have to worry about those things, knowing that they will be done to a high quality, high standard, and that also that they can coach the crew through what we're actually trying to achieve with the ECPR stuff. So yeah, I mean, it's not, we could do it, we can do it without there being an APP at scene, but if they are there, then we are ever so grateful.
And I guess, to your point, we're all sort of learning at the moment, aren't we? Like, from a dispatch perspective, like having the proctor, because there aren't really any pre-hospital perfusionist experts at the moment, right? You've got perfusionists that work in hospital, as you said, but don't do pre-hospital. You've got HEMS consultants that do pre-hospital but don't do ECMO yet. You've got APPs that do medical cardiac arrest. We're all kind of learning together, so I guess it's increasing that exposure as well, right? And certainly for us, like the getting the opportunity to come to these jobs, sitting on the D&D, learning more about it as well. I think it's all great. I know you said that currently the setup with ECAT is that you're either responding by car if it's close, or if the trauma team are on another job. If the aircraft is available, you guys kind of do a bit of a hot swap with a cool little trolley, don't you? And you take the trauma kit off the EC135 and put on the ECMO kit, and then you'll fly to a job, do a really cool Hollywood, exit the aircraft, and they'll do a rotors run in, lift back to the London, see you later, and you guys are off on your merry adventure delivering ECMO with a inevitable taxi ride back to the London at some point. Is that right?
Yes, yeah. So that's how it has ran in 2025. And obviously that whole thing comes with rather a significant amount of complexities and issues and delays. And as we know, time is really important, as I keep saying. So um then having to swap the equipment, or having to take the equipment down to the car before we're even mobile, obviously adds a significant delay. But however, as of this month, the team will actually be deployed by car preferentially. So as you say, operational delivery is complex, and you could assume a car makes more sense. In a perfect world where money isn't a consideration and team numbers are unlimited, maybe you had both, or you'd have multiple teams based on cars in strategic locations across London, much like the APP scheme. But if I go back to thinking about sort of the inception of ECAT was to provide equity of care, or equity of access to an intervention that was not accessible to a large population. So even with the ECPR pathway that we have for the APPs where patients are transported to an ECPR centre in cardiac arrest, there's still a large proportion of the population that won't be eligible for that because of the time frame required to arrive in. And then ECAT aims to reach patients earlier and provide ECPR earlier, increasing their chances of a neurologically intact survival, because that's the aim of the game.
So I know with oh sorry Matt, I was going to say sub 30 was the feasibility trial, right? I'm sure most people are familiar with it. Sub 30 was run a few years ago, feasibility with the aim to see whether or not the team were physically able to get people onto ECPR within 30 minutes. And I think I might butcher this, but I know that they were ever so slightly outside of the 30 minutes. Was it 43 minutes average, something like that, which was still like the fastest times that anyone else had managed to achieve anywhere, but it was with a very, very in a very, very like specific area. It's pretty much like the square mile around the Royal London. Was that right? So basically, if you have your medical cardiac arrest at either like Farringdon or one of the main train stations in central London, then you'll be a prime candidate. But to your point about equity of care, anyone else, like you're never going to be within that time frame, even though it was just a feasibility study. It wasn't delivering the intervention with a hopefully there'll be some survivors from the study, which I know there was two, wasn't there? Is that right? I think, yeah, maybe one, but it wasn't, I know that they weren't looking at like the outcomes was a secondary metric. It was to see whether or not it's feasible to lead to what you guys are doing now. So do you think it is better delivered by car, or do you think having the aircraft has achieved that? Where are most of your jobs? Where have you been doing jobs that are spread out all over London? I guess is the question. Like, do you feel like the helicopter definitely using the aircraft bridges that gap, is able to mean that more people have access to pre-hospital ECPR?
Yeah. So I think that or being able to reach the patients that don't meet criteria for the ECPR pathway because of their geographical location, or because, mainly because we can't get them there within the time frame, is the reason why ECAT exists, is to provide access for ECPR. And when you've only got one team who aims to provide a service to the whole of London within a small time frame, by air is really the only way to achieve this. I mean, you could look at the distances in London and think that they're actually not very big if you look at comparing that to outside of London. But it takes a long time. I mean, you'll know how hard it can be to drive across London to a job. It takes a lot longer than you think it's going to take, and it takes a lot longer than it does anywhere else in the UK. So it has its complexities, and by air is certainly not, it doesn't solve all of the problems, of course, but I think that really is the only way to be able to achieve equity of access, which was the concept for wanting to do pre-hospital ECPR. But there's plenty of issues with that, like I say, and so sub 30 was focused on a very small area, and even then, they weren't able to reach that 30-minute time frame. But what they did prove is that it is feasible to undertake pre-hospital ECPR, and then we've got lots of other places that also have proved that it is feasible to undertake it and are undertaking it in other countries. So the decision has been made in the short term to be deployed by car. Of course, that'll be reviewed and evaluated in addition to the year's worth of data that we've got about the deployments, because we've been deployed so far by a range of car and air. So sometimes it's been because of the proximity of the job to the base or to the location of the roaming team if they are by car, or if they've gone by air. And so we can compare, how many jobs did we miss if we were on the car because we weren't close enough to respond. So all of those things we'll need looking into, and we'll review and evaluate to see what should the chosen method be. And I don't think it's like I say, there's lots of complexities. There's lots of, you could argue it many different ways. And of course, sharing the helicopter with the trauma team has been like a privilege to be able to do that. And we wanted to make sure that we didn't disrupt that service that's already well established, and so that's really important that we consider that in our decisions as well.
And I guess some of this stuff, there's wider conversations going on about HEMS teams generally, right? Like whether or not they're better suited, responding by car, carrying on responding by air as they are at the moment. So I guess the people that are out there that might be asking and wondering, is this service better delivered by car? I guess, it's part of this wider discussion. And actually at the moment, that the evidence, the general consensus is that having this hybrid model where you've got the ability to go by both, as exactly as you said, it's like has got huge benefits and also drawbacks as well until someone brings in the jetpacks. That's what I reckon is the the nice in between. I'm not serious, but yeah, who knows? Maybe drones in the future, like little, how do you feel
Maybe.
about climbing into a drone without a pilot and it just flies you off to a job? Maybe that's 5-10 years ECMO in London. Cool, thanks, Nikki. So I guess the next thing I wanted to ask you about, we talked a lot about ECMO. Why do you feel there's a need to do something different at all? I guess, if I was going to sit here and be like a little bit critical, maybe, you're talking about, it sounds really complex. Clearly there's a lot of money involved. You're talking about having to borrow the trauma team's helicopter. What we're doing at the moment not enough? Like, why do we need to do anything differently? Do we really need ECMO, I guess is the question.
Yeah, so I mean, if we think about why we are, why what we're trying to achieve, which is if like we're trying to improve survival outcomes for cardiac arrest, particularly neurologically intact survival, and that that the data on that seem to have plateaued, the survival numbers. We haven't had much improvement in maybe the last 5 years. So, and we do know, as you mentioned before, that the way to increase survival in cardiac arrest, or the only evidence-based ways to increase survival, is to increase access to public access defibrillators and to teach bystanders to undertake CPR quickly and effectively. It's also obviously cheaper to do than providing ECMO services. However, they're two separate groups of patients, really. That's how I'm looking at it. So we know in patients whose hearts we can't restart quickly, so they're the ones who receive the benefit from bystander CPR and the public access defibs and the things that we know are relatively cheap and do make a difference. But the patients whose hearts we can't restart quickly, so within the first few shocks or within the first few cycles of advanced life support, their chances of survival are next to none. I think approximately 2% in the literature. And those who do get a ROS, so those whose hearts we can restart, they've had a prolonged period of resuscitation. So they've got a much higher chance of a hypoxic brain injury, which, prevents a neurologically intact survival. So the limitations of current resuscitation strategies are that in refractory cardiac arrest, CPR simply can't provide enough oxygenated blood to the brain and expect a full recovery off the back of that. And unlike other organs, which can be supported to recover by various means, the brain can't be supported with medications or dialysis or transplants, for example, after they've had an insult. So once the damage is done, it's often irreparable. ECPR provides physiologic blood flow, like I explained before, so the same in what a working heart and lungs provides to the brain. So as long as it's done in a timely manner, the devastating hypoxic brain injury can hopefully be avoided. Yeah, and in addition to ECPR for these patients, there are a subset of patients that we arrive to that don't meet criteria for ECPR for a range of reasons. But for those patients, and this is also supported by what they've been doing in Sydney, we can have benefit to these patients. It also goes hand in hand with sort of what they're developing with SPEAR. But in the patients that ECAT have attended that don't meet criteria, multiple of them have received RSIs for good airway management and ventilation strategies in ROSC, and have received arterial lines to guide CPR. So either moving like manual CPR, moving the position of someone's hands, or moving a mechanical CPR device to ensure we're compressing the right part of the heart, and providing effective CPR. And yeah, I know in Sydney they've definitely seen improved survival rates and improved ROSC rates with just that intervention. That's without ECPR. So there are benefits for the non-ECPR patients that we're attending as well.
And there's also, correct me if I'm wrong, there's also a cohort of patients who achieve ROSC but are in profound cardiogenic shock who actually really benefit from going on to ECMO as well, right? And this is kind of how ECMO became a thing in hospital, right? You know, patients in cardiogenic shock. So we're talking very specifically about ECPR, patients that are in cardiac arrest without any effective output or flow at all. But there's also that cohort of patients who perhaps, you know, they've been lucky enough, there's been someone trained in CPR, have had access to a public access defib, they've had a few shocks, but, you know, they are in, you know, a really, really ropey place. And, you know, and ECMO generally, I guess my sort of the key term for me that always stands out is it is that bridge, that life-saving bridge to definitive care, right? That, you know, the alternative at the moment is we sort of bolus some dilute adrenaline and sort of do a little bit of sedation and plus minus some paralysis and, you know, hopefully get someone onto a mechanical ventilator. But, you know, if this was me or someone I really cared about who's in that situation, naturally, like they're in that really, really, really thready ROSC where their heart has just had that horrible big insult, and there's this intervention that you can deliver to you know, externally replicate what a normally functioning heart and lungs would do, and it even reverses some of the effects and the pathology of that cardiac arrest. Is that right as well?
Well, yeah, I mean, if you think about an ischemic event versus like infarction, you know, where you've got irreparable damage, if you provide oxygenated blood flow to an ischemic area, you're likely to be able to reverse the damage done. But once after a certain time frame, you know, you've got infarcted tissue, then you know you're not going to be able to reverse that pathology. So if done early enough, you know, we can provide blood flow to the ischemic areas that need it. So whether that's the brain, whether that's the heart. And yeah, a lot of our ROS patients, they've had prolonged cardiac arrest and their hearts have not had oxygenated blood flow either during that time, or not wonderful oxygenated blood flow. So yeah, their hearts are hypoxic, the myocardium's not very happy, it's not beating very well, and that's in addition to whatever has caused them to have their cardiac arrest in the first place. So if they've got a lesion in one of their coronary arteries, that is still there, even if we've got a ROSC. So the heart is still not working like it should be and like it was, you know, in the sort of time leading up to that person having that cardiac arrest. So until they've had their PCI, their angiogram, you know, we don't know what the problem is, and we haven't fixed it. So we need to be mindful of that. So yeah, with ECPR, they obviously are providing a healthy heart's worth of blood flow. So when these patients, yeah, we get a lot of patients, don't we, that are in cardiogenic shock in ROSC, and we're, you know, putting them on adrenaline infusions to try and improve their perfusion. But yeah, that's like you say, that is what that's what VA ECMO initially is there to support, is patients in cardiogenic shock. And yeah, it's a bridge to being able to fix the problem. You know, it gives the brain more time to survive without a working heart whilst we fix the problem that caused the heart to stop in the first place.
And I know actually, you know, I had a real light bulb moment doing the SPEAR course where actually it made me challenge these whole terms, you know, cardiac arrest and ROSC, like all together, because actually, like what we're really talking about are cardiogenically shocked, all shocked patients, right? It's just if we can't feel a pulse, we call it cardiac arrest. If we can, we call it ROSC, but actually they're all shocked, you know. And yeah, you know, big shout out to the EAAA guys because I think it's a fantastic course, and that to me is kind of the where things are more moving, that we're moving away from this, you know, algorithmic kind of approach to cardiac arrest management. And you know what you're talking about is much more targeted, individualized care specifically for this group of patients. So you know, and you got to have in it. I think I'm a big believer. You've got to have innovators. You've got to have people trying new things, like big thinkers, pushing the envelope, trying to do things differently. Otherwise, you know, nothing's going to change. And are we just going to accept that, you know, the overall survivability from out of hospital cardiac arrest is as poor as it is at the moment? You know, we know that doesn't need to be the case. You look at the international registry, and some of the numbers are really, really, really stark and profound and make you think quite a lot, don't they? Is it as much as like 40%, I think, for ECPR overall survivability? Is that right?
Yeah, I mean, if I also have a dashboard where you can have a look at how many patients have received ECPR internationally, and you can break it down by region. You can break it down by adult versus pediatric versus neonate. You can look at who's received VV ECMO, VA ECMO, ECPR, and compare the survival rates for all of those things. And yeah, I mean, if you're comparing it to just a standard cardiac arrest, or even if you compare it to the Epstein cardiac arrest patients, then you can think, oh, okay, well, maybe it's sort of similar, just a bit better than an Epstein cardiac arrest. But what we need to do for ECPR is compare that number to cardiac arrest survival in refractory cardiac arrest, which, like I said before, can be as low as 2%. So yeah, if you're comparing like 30% survival from ECPR versus a 2%, then that's actually pretty significant. And some places who have been doing ECPR for a long time have got amazing survival rates, as high as like up to 50% in some places like Minnesota, where they are so well drilled. They've been doing it for a long time. They've got amazing setups where they are doing it pre-hospitally, but in the back of a big ambulance, which they can do these things under fluoroscopy. So yeah, like the potential is huge, and they are expensive, time consuming, involve highly skilled clinicians, and a lot of interventions that have transformed care for patients have had these things, where these questions posed about, well, is it worth the cost, and is it worth the resourcing that it takes up? And I think PCI was probably one of them. And prior to us being able to take patients direct into the cath lab that having STEMIs. So with lots of these things, I think have been questioned, and rightly so. They should be questioned, because you should be able to have to justify these things, but these are often the things that transform patient care significantly.
I was going to say, like, one of the biggest kind of, I guess, things that critics will say is that it's an incredibly expensive intervention asset. But I think just even talking about the numbers there and what you said have kind of already addressed that. And I guess we talked a little bit beforehand about, like, it's a wider question around health economics, and it's all about perspective, right? Like that one person who perhaps like their job is looking at numbers and, like, sort of like the financial gains and things like that. They might look at this and look at your utilization and look at the number of people that have survived, and question the finances and the finances that are involved. But for those patients that have survived that we know otherwise wouldn't have done, clearly they would say that it's worth every penny, right? So it's all about perspective. And I think kind of what you said earlier, unless you're going to have your innovators, your people that are trying to do things differently, then I guess the important bit is then looking back, right, and analysing it and actually trying to answer that question and work out if it's worth it. But even the paramedic profession, right, like, I guess 20, 30 years ago, when someone first suggested training up paramedics, training up ambulance drivers to be paramedics, there were probably people that felt that, that was a waste of time and money, and actually just get patients to hospital quicker. But, they don't really seem to be conversations that happen that much anymore, unless anyone's talking particularly around my clinical care. Well, but I know other countries are doing it as well, was what I was getting at. Other countries are obviously, you talked about Sydney already, and Minnesota. Like, other countries are actively either exploring this or are currently doing it. And maybe, we can save ourselves a little bit of money by looking at what other people are doing and learning their lessons. Do you want to talk us through that a little bit? Who are the sort of the outliers, the kind of the leaders, the people that are way ahead of everyone else with this sort of stuff, and what is everyone else doing? How does it look different to what ECAT are doing? And the good, the bad, and all the rest of it.
Yeah, so much like, any pre-hospital services or HEM systems, everywhere seems to do it all a little bit differently. But Paris certainly have been the pioneers in pre-hospital ECPR for many years now. But alongside Minnesota and the Netherlands, there's now Sydney and Melbourne. There's areas of Germany, amongst others, that are all starting to do pre-hospital ECPR. They all have slightly different approaches, but I think they couldn't not, because everywhere has a different healthcare system. Everyone has different EMS setups. Some of these countries don't have paramedics, so it's going to be different. So they've got different clinicians, they've got different geography, they've got different selection criteria. Some of them have obviously different financial input as well. So all of those things are obviously massively influential into how their system can work. The London approach, like I said, initially considered a two-person team, which might align more with sort of some of the other systems, like the one in the Netherlands. And then we, after sort of having a sort of lesson on how Sydney had found their first year and what they'd done and how they'd found it, like you said, we can learn lessons from other systems. There's no point everyone trying to reinvent the wheel. And so we have sort of mainly, I would say, our probably system is more closely aligned to what they do in Sydney. But also that's similar because they have their critical care paramedics, which are similar to the sort of HEMS paramedics and APPs that work in London, and their roles and their capabilities, and how the EMS system is set up. So yeah, that's probably how we're most aligned to. But we are trying to learn different things from the different international teams. And I attended the ECPR conference in Prague in October and was able to hear about how everyone, how each system is doing these things differently. And we've obviously got a lot to learn from how they do things in hospital, sorry, as well. These teams in hospital are so well drilled and they've got different setups, and a lot of them have got their pathway where they work heavily with their EMS system to bring the right patients to them, and they'll put them on in a designated room. So both the ECPR pathway for the APPs and the ECAT system has learning from how everywhere else is doing it and trying not to reinvent the wheel ourselves, and there'll be other systems in the UK that are starting or looking into doing this. And the Resus Council have highlighted ECPR in their most recent guidelines again. So it was slightly more emphasis in this guidelines, but they did exist in the last guidelines to consider it as a rescue therapy for selected patients. And then in the most recent publication, it was, specifically mentioned about patients in refractory cardiac arrest from shockable rhythms, should be considered for ECPR. So I think, if our guidelines that set out how we need to be resuscitating patients in the UK are recommending this as an intervention, soon, instead of thinking about ECPR being this out there expensive intervention that hardly anywhere does, soon we'll have to justify why places aren't doing it. And the geography has a lot to do with it, and where these centres are. There's massive parts of the UK that don't have any ECPR centres. So we're so privileged in London to have multiple centres, but some ambulance services in the UK don't have a single centre within their whole patch. So it is just not possible to provide this sort of thing, but we should have equity of access if we know that these patients may benefit.
And a lot of this stuff all sounds really familiar. I remember listening to Gareth Davies and some of the LAA guys talking about the journey with London HEMS and how there were loads of naysayers that, you were talking about needing a helicopter in London, needing an air ambulance, full stop at all. And, you look at how over the last 30, 40 years, how pre-hospital critical care in general was kind of evolved, and all the way to now working, in my other job in for Hampshire Isle of Wight Air Ambulance, where patients on the Isle of Wight don't have access to any specialist care, in the sense that there's no cath lab, there's no major trauma centre. If you're sick, everyone is flown off the island, and it's a real lifeline. So I think this, the equity care stuff that you're talking about is huge. And in terms of what other areas are doing, I guess in the UK, I know KSS have recently gone online with their ECMO team, their service. I only know some little bits, but they've obviously got a much larger helicopter, a 169, and they can get all of the kit on the aircraft and do it with just two of them. So, and I know, whereas other services that have got a smaller, same as London, a 135, are looking at primarily, if they were to deliver ECMO, doing it all by road. So there's so much variation, isn't there, in terms of geography, operational delivery models, even the dispatch. But yeah, it's great to hear that, the conference people are all getting together and talking about it, and kind of feel like it's something that's here to stay now. And yeah, it's great to be sitting from the sidelines watching it all kind of unfold, I guess. Which brings me nicely onto my last question, Nikki. Where do you see the future of pre-hospital ECPR? Is it with jetpacks, or do you think, clearly a bit like ultrasound, like the equipment, right, is getting smaller and more accessible and more affordable? Is that happening with like the kit that you guys are using on ECAT? Like, yeah, where do you see the future of this? Do you think, are there more patients that could benefit outside of just shockable refractory cardiac arrest?
Yeah, so I think the future of ECPR, certainly in the pre-hospital phase, is really exciting. I think that in the initial stages, I foresee expansion within ECAT, but also within the UK, other services like you mentioned, KSS starting, which is really exciting. And and we can't all use the same system because we don't know which system is best, but also one system will work in one area because of how their geography works and where their centers are and what aircraft they've got access to, and that might not work in other systems. But I think it's really important that everyone can share all of their learning, and we can all develop together. So yeah, I think that expansion of the services is one of the things that I foresee. But also, I think we're likely to see expansion of ECAT imminently, sort of within the first half of the year, to increase their team numbers and increase their cover. So, we acknowledge that providing cover 1 day a week has a lot of challenges for a lot of reasons, but we need to be there for the patients that need us. So we've sort of improved the system. We've learned from various jobs. I mean, every incident we've attended, we've learned something new, how to change maybe some equipment that we actually needed, or something that we can do to streamline the process of, like, whether that's a dispatch process, whether that's a mobilization process, or the process on scene. So yeah, we've got lots of developments in that, but we obviously need to be available more to the patients that are there. So and then, evidence changing is likely to alter our inclusion criteria, and we can, move along with that. We'll certainly be open to allowing any appropriate changes and learning from other systems. And like I mentioned about Resus Council guidelines, that's also likely to, expand the services. And then, yeah, any technological advances, they're developing machines that can undertake ECMO. The higher the need is, the more companies that will be interested in making devices that are maybe cheaper, and the more pre-hospital systems there are that are interested in undertaking ECPR, and the more market there is for them, hopefully there's be some more developments in making these machines lighter to carry and more transportable, more robust in the pre-hospital environment. So yeah, I think those things are all likely to develop the sort of any sort of new monitoring, new machines. And as the APP team develops as well, I'm sure they'll have more integration with things that will cross over, like things like arterial lines and being able to sort of support ECPR or transesophageal echo. I know they use that in Sydney, and that would be beneficial for both ECPR and non-ECPR patients in cardiac arrest in terms of supporting their care. So yeah.
Even with dispatch, right? I remember listening to someone a little while ago. It might have been a guest on Owen's show, actually, who was talking about AI and kind of like risk assessing people almost for, like, having a pre-hospital cardiac arrest, for example. Like, you put in your you go and see a GP, you put in some physiological sort of parameters, like look at diet, sleep, and all the rest of it, and it'll give you a risk scoring of, like, what likely based on what you do, like the time of day and where it could occur. You guys are going to be following me around, just follow me around in a car and wait for me to drop. But yeah, even things like that, right, with dispatch and
It's
yeah, the future's going to be yeah, I think if we can, you can find these patients earlier, like be more selective and stuff, then
I mean, if we can predict someone's going to have a VFRS before they have it, then that will make our lives so much easier.
always have, like, walk around with some ECMO in a rucksack. But yeah, like, I think I think if anything, it almost lends more to the need for these kinds of interventions, right? Whereas, like having loads of, like, people that are first aid trained and public access defibs everywhere is for that real, broad, vague, oh, it could happen to anyone at any time. But actually, like with technology, like things are becoming a lot more. I did a bit of a Donald Trump then, didn't I? I did a bit of, it's going to be beautiful. It's going to be big. It's going to be beautiful.
Edit that out.
Yeah. But yeah, I think it's really interesting, mate. Really exciting. Well done, I think, to you, Ben Singer. Everyone else has been involved in it. I think it's yeah, really cool stuff. Really interesting. Good luck with 2026 and everything else that you're doing. And thanks very much for your time.
Thank you very much.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.